welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, hello, hello. Happy Monday and welcome to Brain Chat, my friends. I'm Dr. Mitzi, your board certified neurologist and MS specialist, and I am so excited to be here with you on another wonderful Monday. It is a little dreary here in Atlanta, Georgia, but I'm sure the sun is shining somewhere, and I'm so glad you guys logged in to talk about a topic that I think is extremely important, and I've got one of my amazing super friends, Dr. Stephen Krieger, who's going to be hanging out with us tonight. So when we start Brain Chat, you guys know how we do. Put in the chat where you are logging in from. I love to see people from all over the US, all over the different time zones, logging in and spending a little bit of their Monday evenings with us. So tonight we're going to talk about the course of MS. And first, we also want to thank our sponsors, Genentech, Biogen, IDEC, and Janssen for sponsoring Brain Chat. And so tonight we're going to talk about the course of MS. So this is a really common question that I get from many of my patients. What type of MS do I have? And I have brought an amazing expert on to talk about not only how we traditionally have thought about the course of MS, but also how we're changing that thinking. And so I love to talk about what the next steps are. You know, where are we with the science? What are we thinking for the future? And most importantly, how can we best help you to communicate with your neurology healthcare team to make sure you're an active part of your team. So before we get started, I see a couple people. Someone's logging in from Macon, Georgia, a neighbor to me. I was there not too long ago, I think a couple of weeks ago. Somebody is logging in from Houston, Texas. Thank you guys so much for logging in tonight. And I'm going to go ahead and give an introduction for our guest. So Dr. Stephen Krieger is a professor of neurology at the Icahn School of Medicine at Mount Sinai in one of my favorite cities, New York. He graduated from Columbia College and received his medical degree from Yale University. He did residency at Mount Sinai in New York and also did a fellowship, so extra training specifically in multiple sclerosis at the Corinne Goldsmith Dickinson Center for MS. He's a clinician educator. He was a director of the residency program for 10 years, and he still maintains his clinical practice. And he has done so many different things, including working with clinical trials, as well as doing amazing things surrounding education for the MS community, for both clinicians and for the patient population. And I brought him on today because he's going to talk a little bit about the topographical model, which is a model of MS that he has proposed, that's been published, and also was the subject of an article in Scientific American. All right. And so I see we got some folks logging in from New York City. We got Greensboro, North Carolina in the house, and we have Sacramento, California. And with that, I am going to bring Dr. Krieger up to the podium. Hi, Dr. Krieger.
It's hot in New York right now.
It
is. It's hot. I know you're in Atlanta, but
it's hot. All right. Well, we definitely have some warm weather down here. The rain helped a little bit, but just a little bit. Not very much. Well, thank you so much for coming on to Brain Chat tonight. I'm so excited to have you. We are friends in real life. And so it's always nice to have not only colleagues, but good friends on to help educate the MS community.
All right. So at the same time, we came into this field at the same moment.
We did.
Fellowships right at the same time. So
absolutely. So tell us a little bit about what interested you in MS and how you got into the field.
Yeah, so around the time that I met Dr. Williams is when I was deciding what kind of neurologist I wanted to be. And, I always was drawn to the brain and to behavior and to how we exist and move about in the world and how our brain and our nervous system allows us to do it. But I didn't know that I was going to be an MS specialist until I was during my training, during my residency training. And, I think there were kind of fundamentally two things that moved me. One was I looked at the folks who were running our MS center, Dr. Fred Lublin, Dr. Aaron Miller, and these were people who had incredible relationships with their patients. They had done incredible research. They were moving the field forward. And I just sort of looked at their careers and thought, I want something like that. I want to contribute in a similar way. So that was part of it. But I'll be honest, like the thing that really got me was, and this is like a little bit of a dark thing to say, but when you're a neurology resident, you're working in the hospital and you're taking care of a lot of very, very sick people who've had bad strokes and bad Alzheimer's disease and bad Parkinson's disease, really sick and mostly very old people. And I love them, but when I would walk into the room with somebody who had MS, typically he or she was my age or younger and was doing okay, or there was the possibility that they could do okay, and we had so many things to offer them. And I felt like I could walk into the room and I could connect with the person and they could look at me like I could really do something for them, and I could. And it was the first time I think I really felt like a doctor, like someone who could help people and guide them. And that's what inspired me. And I wanted to just do that for my whole career. So I did.
I love it, and I had a similar experience with Dr. Mary Hughes, who's my mentor. And I just loved the relationship with the patients, that, it was very different from hospital based neurology, and, we were talking before the show about how we want to get more people interested in MS because they just don't get to see it, or what they see is when people are very, very sick in the hospital, but they don't see the other side of that when people come to see you in clinic and they're showing me pictures of their kids and where they went on vacation. And so, it's very interesting. So we were so it wasn't that there weren't MS fellowships before we came through our training, but it became much more common to do an MS fellowship right when we were coming out. So we were kind of one of those first groups, where people were really, kind of starting to do more fellowships and do additional training that was focused on MS. So that was really cool that we were kind of, a little bit ahead of our time, so to speak.
It's
Maybe
true.
just a little bit.
Now, when I see patients and I have my fellows join me, my conversation with my patients, some of them, I've been having those conversations for 15 years,
Yeah.
a dozen years. And so it's really something for my fellows who are brand new to see these relationships that you can have with people and really seeing them through their journey. So I hope to give that to my fellows the way people gave it to us.
Absolutely. Same here. Same here. All right. So let's dig a little bit into the types of MS, right? So I said kind of at the top of the show, we were going to talk about subtypes of MS. One of the most common questions I get from patients is, Dr. Mitzi, what type of MS I have? So let's talk about kind of the traditional thinking when we were in training, and then we'll kind of segue a little bit later on into the show when we talk about your model, about some of the new ways that we're thinking about the types of MS. So, for the audience, tell us, what are the subtypes of MS?
All right, I'm going to do that. I'm going to break with precedent here. I'm going to show a slide.
Yes. So Stephen is the only person that can show slides on my show. So, but the slides, you need the visual. So we're going to put up a picture, so you can kind of see some of the pictures for those who are watching the Facebook Live. All right. And let's add that. There we go.
See that picture?
Yep.
All right. So, when we think about types of MS, what we're really talking about is my boss and my mentor's work, Fred Lublin. These are called the Lublin MS phenotypes. So phenotype is really just how something appears, how it looks. And this is the way we've been drawing this out for 25 years. I'll be honest, I pulled this straight from the Wikipedia page on MS. And I did that intentionally because when someone's being diagnosed with MS now and she Googles MS and reads the Wikipedia page, this is still one of the first things that comes up. So it really kind of starts the conversation, for somebody joining this world. And I think that question, what kind of MS do I have, is sort of right there on the Wikipedia page. It's like, well, there's a few types. So we've used these terms for a long time, and when we get to it, I'm going to talk about how we can even see past them, see over them, and sort of make this more personal. But here's how we've looked at it. Relapsing remitting MS is someone who has these relapses of neurologic symptoms, which then recover. And sometimes a relapse recovers all the way. Sometimes it doesn't. Sometimes it leaves something behind. So a relapse of MS, typically defined as lasting for more than a day. In real life, though, a relapse can last much more than a day. I mean, they can last for weeks. They can recover gradually over weeks to months. So I say that. I think that's important because relapses behave the way inflammation behaves. So one thing I tell my patients is, if you sprain a wrist or you sprain something, and what happens? It hurts that day. It hurts more the next day. And the third day, it's swollen, and by a few days into it, boy, is there swelling there. And then that swelling lasts for days and then gradually gets better. So when MS causes inflammation in the brain or in the spinal cord or in the nerve to the eye, the optic nerve, that inflammation typically takes a day or two or three to start. It lasts for a while and then it recovers. And that's what the MS symptoms do. They don't come and go in 5 minutes or in an hour
Right.
or a bad day. Inflammation isn't that quick. Inflammation takes more time. So kind of knowing what's a relapse and what's a bad day, or what's a relapse, or you slept on a leg funny, or you put your arm on something funny and it tingles for a few minutes and then you shake it out, is an important thing, because everybody, when they get diagnosed with MS, understandably becomes really attuned to what's going on in their body and can be very worried about small things, short things that are not relapses. But this little red lines here, those peaks, those ups and downs, are relapses lasting weeks, days or weeks that recover. The second curve here is what we call secondary progressive MS, and that's where someone starts out having these relapses and recoveries, but little by little, even without a relapse, things gradually get worse. Symptoms develop. People have more difficulty moving, or more difficulty walking, or difficulty with their bladder, or difficulty with their cognition, gradual stuff. And that's what we call secondary progressive. It starts out relapsing, but then secondary to that, afterwards, it starts to become more progressive.
Mm-hmm.
The third type, and I know I'm showing 4, but I'm only going to tell you about 3. The third type is called primary progressive MS. And in this little diagram, it's shown as just a line that's just going up. And what that's there to indicate is that there's disability that is accumulating slowly. Someone's gradually getting worse, but they never have a relapse. They never have optic neuritis or an attack of something that lasts for days and then goes away. It's a more gradual thing. This is a less common form of MS. Roughly 10% of folks, most people with MS do have relapses, but it's felt to be part of the same disease. I'm going to skip the 4th one because we got rid of that category a couple of years ago.
The 4th one has been variable. So there are some graphs where it says progressive relapsing, some it says benign. So that 4th category has kind of, fluctuated over time.
We'll take that one out.
You will take that one out. I agree.
But, I think this is all useful, but it's very abstract. And I think when someone says, what kind of MS do I have? It can be really hard for us to know, because if someone hasn't had a relapse in the last 5 years, do they still have relapsing remitting MS? If someone has been gradually getting worse, but it's really subtle and we can't even really see it, do they have progressive MS? It's a challenge. It really
And I think
is.
the other part of that challenge, Stephen, is, the medications that we have now are very effective at decreasing the inflammatory part of MS. So they're very good at decreasing or getting rid of the relapses. So when we see someone who may be worsening, is that really just how their MS is going to behave? Is that how it's going to go? Or is it because we're giving them medicine that's getting rid of this other part and all we're seeing is the progressive part? And so that's also a big question that many of us have, especially when people have been on treatment for, let's say, 10 or 15 or even 20 years.
Right. And even in the way you asked that question, the way you brought that up, there's something very there's something modern and new about what you just said. You said, and I agree with you, we treat with these medicines that stop the inflammation, takes out the relapses, but could they still have the progressive part? And that idea, I feel like, is a newer idea. It used to be that we would say people have relapsing MS at one point in time, and then sometime later they have progression.
Right.
And what you're saying is, and I agree, it's kind of in the topographical model that maybe both of these things are happening at the same time, and we can do something about the relapsing inflammatory part. We can't always do something about the gradual part, and it's sometimes hard to tease out. Is someone just getting older?
Yeah.
Or is it their MS?
Because, you can get old arthritis, you can get all the stuff that, people get as we mature, right? And
Right.
so sometimes that can make things difficult to tease out. I tell my patients all the time, I wish I had like a little circle I could draw and I say 75% of this problem is from your MS and 10% is from this and 20% is from this, but it's not always that easy to tease out, so sometimes we're able to kind of figure out what are other things contributing, and sometimes we're not quite as successful, and we have to make the best decision based on the data that we have. And one other thing that I thought was really important that you touched on earlier was in between relapses, those periods of stability, remission. And so that's a word that I have people commonly use. And I try to make sure that I explain that remissions with MS are not like, let's say, remissions with cancer. When someone has a remission with cancer, we think of the absence of disease. There's no evidence that that cancer is there, right? We can't find anything. But with MS, a remission can be a period of stability. It doesn't mean that everything goes back to normal. It means that you may have an episode, let's say, where your vision goes out and you may recover 80%. And if you keep that 80% for 5 or 6 years, that's a remission, right? And so we have to make sure that when we're educating our patients and we're talking to people that they clearly understand that, because oftentimes when people think of remission, they think I should go back to normal. And if I don't go back to normal, then there's something wrong or there's something else going on, aside from that initial episode from the MS.
I think it's such a good point. And, it's part of why we care so much about preventing relapses and why we care so much about using our treatments to stop the inflammatory process. As you said, every relapse could leave some amount of symptoms or disability behind. And so every relapse we prevent, it's not just about preventing the bad few days or the bad couple of weeks. It's about preventing damage in the brain or in the spinal cord, damage that could leave symptoms behind that could be forever. And so that is part of the call to action. That's how I think of it for using disease modifying therapies. We call them that, disease modifying therapies, DMTs, because they modify what's going to happen to someone. They change the course. So part of what the topographical model is about is how can we describe that course better so that we understand what it is we're trying to prevent.
Right. So important. And I think something that we don't stress enough, now, of course, I encourage everyone, to talk to their own healthcare professional. Obviously we're not offering medical advice, but certainly I've seen a huge difference in what my waiting room looked like 15 years ago versus what it looks like now, and we do know that the treatments do make a difference in how people do, at least, for a significant period of time, because we know that MS is a lifelong disease. And so that's why it's so important for people to, go see their doctors, talk about whatever plan is the right one for you, but make sure that you're following up and getting seen, because ultimately our goal is to try to prevent some of that disability. And we know that our medications can do that. So that's extremely important. So when we talk about, we can't predict, right? Every person is different. One of the difficulty with relapses, especially for some of those who may come to see me and say, oh, I haven't seen a doctor in 10 years. Back in the day when I used to have a relapse, I get a, IV treatment and it would go away. But this time it didn't go away. Part of the problem is that we can't predict when that episode will be that the symptoms will completely go away, or if that episode will be one where you have things that last. So one of the things that we try to do is we try to create what we call prognostic factors that help us to say, will this person more likely have a milder course of their MS, right? We know that MS can be disabling for everyone, and we don't discount any disability, whether it's mild or severe, right? But who's going to have maybe a milder course, and who's maybe going to have a more severe course potentially? And those are some of the things that we use to help us determine, when we're thinking about medications, what medication would be most appropriate. So, talk to us a little bit about prognostic factors and what that means when a doctor's saying, because of this, we think you need this type of therapy. You may be more likely to have a worse course with or a harder time with your MS.
Yeah, it is still a difficult thing for us as a field because I can't, as you said, I can't tell a young woman when I see her for the first time if she's destined to have another relapse in a month or a year or in 10 years. But we do have certain things that we can use that tell us something, allow us to gauge how severe is someone's MS likely to be, and gives us a little bit of guidance about what to do about it. We can talk about a whole lot of different prognostic factors, but I'll talk about one or two that I think speak to my view on the disease, and will speak a little bit to the model that I'm going to show you. So when we look at the MRI scan, the MRI shows us all the lesions that someone has ever had. I used the comparison with inflammation in the body before, and I'll use it here too. Inflammation, if it damages a part of the brain, causes a lesion. Once it heals over, it scars up. And that lesion, that scar, is forever. In the same way that a scar on the skin, it might be a year old, it might be 10 years old, but you can still see it. A scar in the brain, a lesion from MS, is the same in that sense. The words multiple sclerosis just came from the old French for multiple scars. So how many scars, how many lesions someone has tells us a little something about how aggressively the immune system has been attacking that person's brain and spinal cord. So a person who has 2 or 3 little lesions, we're a little bit reassured by that. It's not a promise, it's not a guarantee that they won't have more. We still want to prevent it, but it's a little bit reassuring. Well, when someone comes in, they're newly diagnosed with MS, and we look at their scans and they have dozens upon dozens of lesions, we worry a little bit more, because even though the person might look great, and I'm gonna show you why in a minute, that tells us something happening below the surface, below what we can detect. That person has already suffered dozens of places of damage, and that makes us worry. The other thing along the lesion side of things is, and I think this is perhaps the most important, is where the lesions are.
Absolutely.
So, we always talk about how we don't use 75% of our brain or whatever. Well, we use most of it. We use it all the time. But the reason why we always sort of learn that growing up is because you can do without lots of little spots in the brain. The brain can work around it.
It does.
And so there are lots of places in the brain where we could hide a lot of lesions and never see symptoms from them. But if a lesion lands in a place in the nervous system that is more sensitive, that doesn't have as much ability to compensate, work around, like let's say the optic nerve. The optic nerve is just a thin little tube of wires. If you put a lesion in there, it blocks the signal from that eye, and someone has vision loss. The spinal cord is also kind of a tube of wires. It's not as vast as the brain. It's pretty much just a highway. And if you put a lesion in that spinal cord, close a few lanes on that highway, the signals don't get through. And there's not a lot of ways to work around it. So where the lesions are, their location on the map of the nervous system, I think is the most important prognostic sign, what makes me worry about someone. And I'm going to show you how that relates to this model in a minute.
I call the spinal cord and the brainstem, which controls a lot of the automatic functions of the brain, I call them expensive real estate. And so I say there's a lot of function packed into a very, very small area. So that area is expensive real estate. If we get messed up there, we're going to be in big trouble.
I
a
wrote a
lot of
little
the time.
editorial about this a couple of years ago, and one of these MS journals asked me to write this thing. And I think they knew it's because I care a lot about where lesions are. So they asked me to write this editorial. And so I thought, all right, what would a New York-based neurologist, what would I call this paper about how important it is where the lesions are? So I called it, to use your real estate metaphor, I called it location, location.
Location. I knew it.
I think for
Absolutely.
a Manhattan-based, neuro to talk about. So I agree with that a lot.
Absolutely. Yeah. So now let's talk a little bit about your topographical model. I'm really, really excited to talk about this. And I talk about it a lot with my patients. Sometimes I pull out the slide and show them the slide, but, a lot of times I describe it. So traditionally, with the models that we've had, they have served us very well, right, to try to describe what's going on with MS. But as we're learning more about the disease and as we're seeing people, especially as our medications are becoming more effective, we're seeing that oftentimes people have multiple things going on at the same time. So they don't necessarily fit in that neat little bucket. It's not like I'm relapsing remitting, right? 85% of people get diagnosed with relapsing remitting MS. And then, boom, tomorrow I'm secondary progressive. It doesn't quite happen like that. And so, I really love the way that you created this model to try to explain a couple of things. One, that there are often multiple processes going on at the same time in MS, but especially I think it does a really good job of explaining how later on in disease, people say, Dr. Mitzi, I don't feel the same, but you say my MRI looks the same. Every time we get my MRIs, they look the same, but I feel worse. Why is it that I'm changing, but my MRIs or my imaging is not changing? And I think your model does an excellent job of explaining that. So I'd love for you to tell us a little bit more about the topographical model and how we're kind of changing that thought process about how we think of the course of MS or people's journey of MS over a lifetime.
Well, I appreciate that. And I got to say, hearing from you, I'm going to share my slide here. Hearing from you that it's meaningful to you and informs your practice means an enormous amount to me. You are a leader in this field, and your patients really look to you, Dr. Williams, not just your patient, but people around the country, obviously, watching right now. So there's nothing more gratifying to me than knowing that the thing that I've put out into the world resonates with you and that you can bring it to your patients. So thank you for that. And so I'm going to spend, this will be like 5 minutes, it'll be like a 5-6 minute little mini presentation of my life's work here. And then I'll stop sharing the slides and we can talk about it and see what questions you have. So here's how I would start. When I talked about lesion location being so important, there are really a few places in the brain and the nervous system where MS lesions kind of have a tendency to go. As we said, the spinal cord and the optic nerve, these sensitive, simple structures, you damage the spinal cord and the optic nerve, it typically causes symptoms. To Dr. Williams, your point, the brainstem, the cerebellum, also right there with the brainstem, the base of the brain controls so many of its functions. And then the hemispheres of the brain, the big areas, the less expensive real estate, to use that metaphor, of the hemispheres of the brain. So these are the locations where MS lesions typically go. The way I would visualize, and what is in the topographical model, is the idea of a map. Topography, if you picture a topographical map of mountains and valleys, hills and streams, it's places where in the nervous system has the damage been done and where in the nervous system has been spared. So if we take these locations and put them into a topographical map of peaks and valleys, that helps us to have a sense of where the lesions are in different parts of the nervous system. The shallow end, spinal cord and the optic nerve. The middle, the brainstem. The deep end, the cerebral hemispheres of the brain. So what is this water? The water in this model is the ability of the nervous system to compensate, to work around, so that the things that are submerged below the threshold are the things that are compensated for that you might not feel. And we, as the neurologists, might not see. things that are clinically silent. So this pool of reserve, the central nervous system, increasing amounts of what we call reserve, the ability to compensate less in the shallow end and more in the deep end of the hemisphere. So, okay, that's kind of the starting point. That's the image. What does that mean when I say lesions in a place in the brain? How do they look in this model? It's a conceptual model. It's a way of imagining what's going to happen in MS. And Dr. Williams mentioned an article in Scientific American about this that came out back in 2015. That was written by a medical writer named Brett Stetka, and he coined the phrase the leaky pool model of multiple sclerosis, which is
I like it.
kind of how it's been known ever since. So what are the lesions? Here you see on the top a lesion in the base of the brain and the brain stem, and then there you see that lesion breaking the water surface, crossing the threshold, causing brainstem symptoms. So a lesion in that spot, and you can see it on the MRI with the arrow, might cause vertigo, double vision, blurred vision, imbalance, because that part of the brain called the pons really controls those functions. So that's how we would look at an MRI and how it would look in the model. But where this thing really, I think, speaks to the MS journey is when we animate it. So this is a 1.5 minute video, and I'm going to play it and narrate it for you. So what happens in MS? First, lesions might start to form. So
okay, we can't see the video,
Dr.
Krieger. Hold on 1 second.
I appreciate you telling me that. Otherwise, I'm going to talk about a video you can't see.
Okay, do you have it up now?
Yeah, can you see anything?
Okay. Well, so I still see the topography, the original slide 3.
All right. So let's see. Hang on. What do you see? What do you see now?
Same thing. Hold on 1 second.
So it is not moving, is what you're trying to say.
Yep, it's not moving.
I have an idea.
Okay, I see a change now. Okay, now I see a change.
So can you see anything happening now? Do you see lesions forming?
Yep, I see.
All right, let's look at it this way. So here you see lesions have formed, but those lesions didn't cross the threshold of the water. So they were clinically silent. We call this radiologic isolated syndrome. But years later, what often happens is a new lesion forms. That one's in the shallow end. You can see that across the threshold. That was a first attack, what we call clinically isolated syndrome. And then what happens? More lesions form. Some of them clinically silent. Some of them we could only see on an MRI scan, but some of them cross the threshold and cause a relapse and recovery. Now, the time frame here is years. Years are passing. So this is relapsing remitting MS. Someone who's had multiple relapses with recoveries, multiple lesions that form. But here's the thing, Dr. Williams, that you were talking about before. There's a progressive part of this story. And even while these lesions are forming, the water tank is draining. The water level is going down. This is why it's been called the leaking pool model, because as time passes and that water drains, that reserve is getting lower, more and more of that underlying disease becomes obvious. And that's what we think of as secondary progressive MS, someone who's getting worse gradually. Those lesions in the spinal cord or the brainstem kind of doing more clinically visible things, more weakness, more numbness, more difficulty walking. Gradually over time, even if no new lesions are forming. So that's what we think of as secondary progressive MS. So what this little video tried to do was take us from the very earliest manifestations through relapsing remitting MS, through that unclear time where maybe there's a little bit of progression, through to late long-term secondary progressive disease where the progression is very apparent even if the MRI scan isn't changing. I put this up here and I do it with a little bit of nervousness to show this in front of people living with this disease. When I first presented this, a lot of the scientists and doctors said, "Oh, this is great, this is useful. Don't ever show this to your patients," because I think they felt it was too real. It was too honest, and had a foreboding quality to it. And I get that. At the same time, though, a lot of nurses and nurse practitioners and younger doctors and patients saw this and they thought, this opens my eyes and I want to share this with people, and I want patients and everyone in the MS community to see it and understand what we're dealing with. And I favored that way of doing things, which is to share it and really try to have people understand what we're looking at. But I have one more thing to show you, and then I'll pull down the slides. So the story I just showed is the enemy, if you will. It's what we're trying to prevent. Let me now show you what we're trying to accomplish, because I think that's really important too. So this model is able to show severe, terrible MS, what you just saw. And it's also able to visualize and allow people with MS to visualize what we're trying to do. So here's what that looks like. This person, can you see this moving also? You see the water moving at the top? Okay. This person in this example also has MS. She too has lesions that formed, didn't cross the clinical threshold that time to cause a definitive relapse, but nonetheless, were real. Sorry, I think I just screwed it up. Let me play it again. So as time passes here, this person also has other lesions that form. This is what in MS language we call dissemination in space and time, new lesions forming in different places. This person has relapsing remitting MS. Sometimes the lesions cross the threshold and cause a relapse, and other times they are hidden below the surface. And when we just look at the person, we don't see anything. But there's a difference here. These lesions are smaller. There are fewer of them. They're not happening as often. They recover better. And, super important, the tank stays more full. Even though the tank is draining, because as we age, is what we were talking about before, as we age, we all lose some reserve. We can't do when we're 47, just to make up a number not related in any way to myself.
Right, because 47 is not old. Let's be clear.
No, but we can't do when we're 47 what we could when we're 27. That's always true. But in MS, people can lose reserve. They can lose brain volume faster than just normal aging. And in this example, the tank stays more full. The disease remains compensated for under the surface, even in this example, 20 years in. So this is the treatment goal, trying to do two things: prevent lesions and relapses, so keep the disease topography kind of flat, and also to keep the tank full. How can we keep the brain and spinal cord as healthy as possible, maximize reserve, keep the disease under the surface, and so that 20 years into it, we haven't maybe cured the disease, but we've tried to keep it as submerged as possible. And that's where I think a lot of things that people can do to advocate for themselves and empower themselves are important. Diet, managing obesity, managing other cardiovascular risks to the brain like diabetes and high cholesterol. This is where I think physical therapy and occupational therapy and exercise is so important, because it might not fix the lesions, but it keeps the brain healthy so that it can compensate for them. This is where I think social engagement, cognitive engagement and enrichment is so important, because it keeps the brain forming new connections, keeps the brain healthier. It doesn't let it dwindle. So when I talk to people about how to treat MS, I talk about our disease-modifying therapies to prevent the lesions, and I talk about what people can do to empower their own wellness to keep the tank full. That's the message that the topographical model is trying to get across.
Absolutely. Absolutely. I love it. I love it. Every time you do it, I love it even more. So I think this is so important, right? So, not only what it can look like in the most severe case, but what are our goals? What are we trying to accomplish? And I think this is extremely important for us as healthcare, providers, as well as for people living with MS to understand, right? Because oftentimes when we talk about treatments, people say, well, I've read that study and it only works 50%. So why should I take something that only has a 50% chance of working or a 60% chance of working? And, certainly our medications have their limitations, but I love how you tied in the fact that not only does medication play a part, but, my favorite Dr. Mitzi-ism, medicine plays a part, you play a part. No medicine will get rid of the part that you play in your own health, right? So it really emphasizes empowerment, right? People say when they get diagnosed, how did I get this? What can I do to help myself? And it's important to recognize that in order to keep that tank full, there are things that you can do, for your overall health. And when you do well with your overall health, it also helps your brain health. Those two things are very, very closely tied together. And I think that if there's anything that people get out of this podcast, this particular one, I think that that's something that they definitely should, take with them, that making sure that we're doing those things, the medicine certainly helps and certainly has made a difference. But also there are things that you do, whether it's stopping smoking, if you're smoking,
Oh, yeah.
that healthy diet, exercising, whatever that looks like. I'm a big proponent of meditation and mindfulness practices, right? All of those things, decreasing stress, all of those things can help keep that tank full. And so when I talk with my patients, I call it your bounce back. So I use the example of, my kids, right? So my daughter can fall and like scrape up her knee, and then like in a week, it looks like perfectly new skin. If I fall and scrape up my knee, I look like, I need to get some type of plastic surgery. So my bounce back is not as good as her bounce back, so we want your bounce back to be as good as possible, so that if you have, those areas of injury, you don't have as many symptoms from them, or you don't have decline from them, because your reserve, your tank, is full. What thoughts do you have? So we're kind of coming up on the end. Man, that went fast. So we're kind of coming up on the end here, and I always want to leave people with empowerment, which I think we have done to a certain extent. But on the other hand, what should people be asking their doctors, about how they will do long term with MS, or what should they be asking them about the course of MS, or should we be asking about it at all, or what should we be, what should they be going back to their doctors to talk about when they talk about the course of MS and where they are in their journey?
Great. So yeah, I'm happy to try to answer that. I mean, I think, yeah, and you said a few of the things that people can do to empower themselves that I forgot to mention. So smoking, huge one. Anybody who's watching who has MS who smokes, that is draining your tank. It's a toxin. So whatever you can do to kick that habit, I strongly encourage. So yeah, I mean, I think what the topographical model in essence is trying to do is it allows us to visualize different things that drive the disease course, and in so doing, it's allows us to depict the enemy and it allows us to depict the goal. And I think having a goal is really, really important, to be able to visualize that. So when people talk to their doctors or their healthcare providers about their MS, in a sense, that's the question. Are we achieving the goal? How close are we to achieving the goal of keeping the MS as well treated as it can be? And to use the metaphor of the topographical model, is there any evidence that there are new lesions, new topographical damage? And if so, where are they? Where were my new lesions? Were they somewhere in the hemispheres of the brain that might not cause any symptoms? Or were there lesions in the brainstem or the spinal cord, which we now have seen can be so much more damaging? So that's a question one could ask their doctor. Are we achieving the goal of no new lesions? And if we haven't quite achieved that goal, where are these lesions and how many are there? Because now you can kind of see how those can drive bad outcomes, and preventing them is the target. On the other side, you could say to your doctor, your healthcare provider, do you think I'm progressing? Has there been anything that you've seen change physically or in my abilities or on my physical neurological exam to suggest that things are gradually getting worse? Is my tank draining? Am I losing my ability to compensate? and what can I do to try to foster brain health and wellness? So just because we're saying, oh, change your diet and do exercise, you could ask your doctor, should I change my diet?
Right.
Do you think I'm overweight? Am I obese? Do I have risk factors in that regard? Should I really do something different? Should I be exercising? Would I benefit from physical therapy, occupational therapy to try to
Right.
boost my reserve up? All those things. So it's, instead of asking what kind of MS do I have, I think it's irrespective of what kind of MS it is. Is there evidence of relapse or lesion? What can we do about it? Is there evidence of progression? What should I be doing about it? I think that's a very health positive way of approaching it, and uses the topographical model language in a sense, or way of visualizing it. And I'll just say, if you guys are interested in that, two or three ways you can find out more about it. You could Google the words Krieger topographical model, and you'll see a bunch
Because
of
I saw
stuff.
somebody asked about it in the chat. They asked how could they access the model.
Yeah, you can see that. It is actually, what I'm showing you are screenshots or videos from an iPad app. So
Okay.
if I'm promoting my own product here, it's a free product. So I feel okay about
Okay.
promoting a free service.
Yes, tell us about it.
It's an iPad app. It's called MS Topography. It only runs on an iPad, though, not a phone or an Android or whatever. But if you have an iPad, MS Topography on the App Store, it's free, and it'll do all this stuff.
Is
So
it one word or is it two words?
it's one word. I couldn't get, little behind the scenes, I couldn't get the words topographical model of MS under the little app, on the home screen. It's too long. So we had to shorten it to MS Topography in the App Store. Anyway, ways that you could see it if you really want to. But anyway,
Awesome.
those are some of the ways I would encourage people to ask questions about
Awesome.
their MS journey.
Awesome. Well, I love it. I love it. I think that we've given people a lot of tips that they can use. This has been an amazing conversation. We have a couple of questions, so we're just going to address a couple of them because some of them are kind of a little bit not necessarily related to our topic, but a couple people asked, is Bell's palsy related to MS? And someone also asked, is a positive ANA related to MS?
Got it. So a positive ANA is a test for autoimmunity in general. It's a blood test. It is not specifically related to MS. It can be seen in MS, but it doesn't point to MS specifically. MS is unique in that it is an inflammatory disease just of the central nervous system. It's really not an inflammatory disease elsewhere in the body, or really all that visible in the blood. So positive ANA is kind of neither here nor there for MS, but it suggests that somebody might have a background of autoimmunity and could potentially have other autoimmune conditions like lupus or thyroid disease. But it's not specific for any one disease, and it's certainly not specific for MS.
Yeah. All right, perfect. So this has been an amazing, amazing discussion. Thank you so much, Dr. Krieger, for coming on and lending your expertise. I see in the comments and in the chat that many people have gotten quite a few things out of this discussion, and I'm sure that they will be going and looking for that topographical model to learn more. And so thank you all so much for tuning in. Thank you, Dr. Krieger. Thank you to our sponsors. And we will see you again in 2 weeks for the next Brain Chat, everyone. Have a great evening.